Hello, everybody. Um, I'm Dr. Rachel Gluck. Thank you so much for coming this morning. I know we're just 2 minutes after the hour. I want to give people just another couple of minutes to stroll on in and arrive. Um, I'll tell you a little bit about myself just while I let people arrive. I am a reproductive psychiatrist. I'm also an addiction psychiatrist. And I do see patients at MINDTherapy clinic. I primarily see women and well, anybody really virtually. And so I'm happy to you know, see anybody who needs any additional help with their anything that maybe gets brought up today that feels personally relevant. Um, Any case, I'm actually originally from the East Coast. I did my undergraduate medical training, residency training at Emory University in Atlanta. And I did come out to UCSF for my addiction training, which is how I got connected to Mind Therapy. It's where I did some additional training, some fellowship training in women's mental health and integrative psychiatry as well. My interest in this field really goes back really quite far, though. I began in a neuroendocrinology lab while I was an undergrad, where we were studying psychosocial stress and infertility. I then spent some years researching or working in a research lab that was looking at how depression and trauma affects metabolic health of Black women, and did some cognitive attention bias research as well in adolescence and looked at some of the gender disparities that arise in adolescence. So today I'm going to walk you through what I'm passionate about in women's mental health. But it is a really, really big area to cover in really just such a short time. I'll probably go for maybe about an hour today, a little under. So I've chosen to talk about just a couple of things that I spend the majority of my time educating patients about when I'm working with them. And hopefully this is something that you guys can take with you to apply to your own selves, your own psychiatric journey, and maybe bring to your psychiatrists and therapists as well. So just a disclosure, I have no conflicts of interest to disclose. However, the information provided today in the webinar is really just for your educational and informational purposes. It's not medical advice, it's not diagnosis or treatment, not intended to be a substitute for professional advice from your own physician or health provider. So always seek the advice of your doctor with any questions you may have regarding a medical condition. Don't disregard professional medical advice or delay seeking care because of something you've heard or read here. And reliance on any information provided is at your own risk. So we have to include that medical legally, but it is just a reminder that today is primarily for your educational purposes. Okay, so before we dive in, here's what I really hope that you'll take away in the next hour. So by the end of the talk, I want you to have a better understanding of why women's mental health has its own distinct story, a clearer picture of the biology that connects your hormones to your brain. So understand how reproductive hormones affect your brain, and why these transitions, like perimenopause, pregnancy, premenstrual window, are psychiatric risk points for you. And most importantly, I'd like to help you with the language to bring to your providers to talk about what's going on. Just hope you feel more equipped to advocate for yourselves. Okay. So a brief note on sex and gender. So reproductive psychiatry, it centers on the effects of female sex hormones, but these issues really can affect people of all genders. And throughout the presentation, I'll use the words female and woman interchangeably. I'm referring to biological sex, not commenting on gender. I do work with a handful of trans or genderqueer individuals, so just wanted to acknowledge the limitations of the words I'm using today. Okay. So hopefully everyone's settled in and ready. I won't be taking very specific, like personal questions about mental health. If you do have anything that you'd like answered, there will be some contact information at the very end of the session, and you can reach out to us. If you have questions more broadly speaking about anything that I'm presenting on today, or if I'm unclear about something you'd like a clarification, you can use the Q&A to submit a question. Corinna here has kindly offered to help monitor and let me know if there is a question going on that you've submitted. So please feel free to pop them in as I go along. So, why does women's health deserve its own focus? So, I'd like for you to meet Maya. She's a fictional patient, just from thousands of real stories. This is an example of someone that I often see in my practice. So, age 14, she goes to her doctor and she says, I just feel so dark the week before my period. I feel like a different person. It goes away, but then it comes back really routinely. And, she's told by her pediatrician it's normal. These are just teenage hormones. Um, PMS is normal. This is part of what it means to be a woman. And in her 20s and 30s, it progressively gets worse. So she finally goes to her OB and she says, the week before my period, I just can't function at all. It does lift. It's like a switch flips that day I start my period or the second day. And I just wonder, like, who am I? And which person am I? Did I imagine it? Um, and her OB gives her the oral contraceptive pill. So, Yaz or something, maybe you guys have all some of you may have been on an oral contraceptive at some point, and unfortunately, it makes her mood worse. She's low all of the time now instead of just 1 week out of the month. And so she goes back to her OB. The OB says, oh, okay, now you're depressed. Let's give you an antidepressant. And unfortunately, as I see in my practice, no one really investigates, well, when does this occur? What kinds of symptoms are you experiencing outside of just that low mood? So she's on oral contraceptives and an antidepressant until she wants to get pregnant. And she decides she's going to stop her antidepressant because during her pregnancy, she doesn't want to hurt the baby. And she thought it would be fine, but she unfortunately was not fine. And by that third trimester, she's really barely functioning. She tells no one because she's supposed to be happy. She's having her first baby. So she white knuckles it some more. And around age 50, she starts to experience more mood stuff come on. She's, been off this antidepressant for a number of years now, and she kind of knows in the back of her mind, menopause. I might feel some moods come and go. But it does feel different than other points in her life, than other depressive episodes she may have experienced or anxiety episodes she may have experienced. And it really reminds her of how she used to feel when she was 14, when she first started menstruating, or in her 20s and 30s, before her period, or even that time during her pregnancy, before and postpartum, where she just wasn't herself. And so she's finally sent to a psychiatrist, and that person often is me. And she's finally, bringing this whole history, and it's clear there's something very hormonal going on, right? So this is not one person again. This is so many women, dismissed at 14, misdiagnosed in her 20s or 30s, undertreated in her pregnancy period, and then maybe finally getting some answers around age 50. And I'm sharing this not to vilify primary care doctors or OBs or even other psychiatrists that you may have seen. Truly, reproductive psychiatry is a brand new specialty. And part of that is because there have been these long research gaps. Really, we've only just started in 2016, truly looking at sex as a variable in our clinical research. And so, just to give you a little bit of the history, so in 1993, really not that long ago, Congress had to pass a law requiring that women be included in clinical trials. Before that, it was common to only study drugs and treatments in men and then apply those findings to women. And the thinking here was that female hormones really introduced too much variability into the data. And so women were just left out of that research. 1993, the NIH mandated women were to be included in clinical research. It was a really big step forward. However, the inclusion did not mean researchers were required to analyze women or female sex as a variable. So while women were now in the studies, the trials did not power, so they did not study enough women in order to have to be able to use the statistical analysis to identify any sex differences. So, it took another 23 years wasn't until 2016, as I mentioned, that the NIH finally mandated sex be considered as a biological variable in preclinical research. And so now the question I want to address directly, because it really matters for everything we'll talk about today, is one more bit here. So now we're finally researching women, but pregnancy is still an area where women are omitted from these clinical studies. We can't do randomized controlled trials in pregnant patients. We can't, for ethical reasons, we can't say, this group of women who are pregnant is going to receive drug A and this group is not, because if we don't know the outcome, we don't want to be exposing women to the potential harm that it may cause. But even if we don't have a randomized controlled trial, it doesn't mean we don't have information and reliable, good information. We know from decades of careful observational data from registries, natural experiments, just general biological plausibility. We have hundreds of thousands of women in across these types of studies, the observational studies, the cohort studies. We know what it looks like to have been exposed to these medications during pregnancy. So we have, for each many different classes of medications, we can say pretty confidently, if you do take this medication, this might be your outcome. Because even though we don't do randomized clinical trials, randomized controlled trials, we do still treat women when they absolutely need it. And that has been, again, hundreds of thousands of women in these observational studies and in these cohort studies. So we do have a fair amount of data. And so when I later on today talk to you about the safety of antidepressants during pregnancy, the data comes from some of the largest databases that we actually have in medicine. And I trust it enough to use it in my own clinical recommendations. And I would like for you guys to be able to trust it too. And at the very end, I will provide you a link to a website that is run by Harvard University. They are the first group, the first academic center to create a women's mental health clinic. And for the last 30, 40 years, they have been the real power horse in collecting information during pregnancy and in publishing what they have found. And so they have a really wonderful website that I direct all of my patients to when they have questions. And of course, things that, if we don't have enough time to fully go over them during our appointment, oftentimes they're able to find what they're looking for through that website. Okay. So even though we don't have randomized controlled trials, we do know a fair amount about the sex differences in psychiatric illness. So we do know that so this chart gives you an idea of what women experience more often than men and what men experience more often. So here we have eating disorders. Women are 3 times more likely. PTSD, women are 2 to 4 times more likely to be diagnosed with PTSD. Depression is 2 times more common, anxiety almost the same. Bipolar and schizophrenia, those are about equal. And then these are considered our externalizing disorders, so substance use, suicide completion, those are more common in men. And so there's a really important question here. Is this biology or is this simply because women are leading harder lives, more trauma? We know that women are exposed to significantly more trauma, childhood specifically, than men are. So is that why they are more likely to have PTSD? Um, is there more caregiving burden, more poverty, more discrimination against women? So is it lifestyle or is it like environmental or is this biological? And the answer really is both. Both of these things contribute, but that's okay because we know that the biological piece is real and it is actionable, regardless of what else is contributing to the clinical picture here. Um, and so because we know that women are more likely to experience things like depression and anxiety. If we actually break this down and look across a woman's life, across the lifespan, we actually see some really interesting trends here. And I actually pull this up oftentimes for my women who come to me with any kind of mood episode in their perimenopausal years and they just don't understand. And I like to show them that, before puberty, boys and girls experience mental illness at around the same, or depression here, around the same rates. And there's even a little tiny period here where boys do appear to have a higher rate, are diagnosed more frequently. But then around age 13, women or young girls, that number skyrockets. And then throughout the reproductive years, so from puberty through perimenopause or menopause, women and girls are twice as likely as men, as you saw in the prior slide, 2 times more likely to experience depression. And during this period right after puberty, and then during this perimenopause peak, women and girls are actually at an even greater risk than their baseline here, outside of these sort of higher peaks. And so this is really telling us something. The elevated risk of depression in women is not evenly distributed across the lifespan. It really tracks with these really important hormonal transitions, which I really think is really telling. It's really telling here that something is happening biologically. And so, if you're a teenager who suddenly felt like a different person, which I think many people do, or struggled in ways that felt really out of proportion to circumstance, I think this graph may be part of that explanation that you never got. And then even outside of depression, which affects men and women both, there are some conditions that really affect women only. Um, you know, these are entirely female-specific psychiatric illnesses that are caused by hormonal events during the female reproductive lifespan. So the first one here is PMDD, or premenstrual dysphoric disorder. It affects between 3 and 8% of menstruating women. That range is because this really is a disorder on a spectrum. We know that premenstrual symptoms, we talk about that in the vernacular. We know women often feel a little bit lousier prior to their cycle. And so where you differentiate like normal amounts of lousy from a disorder, where you decide to kind of put that boundary affects what the rate is here. So up to 8%, or maybe one in 10 women. And in premenstrual dysphoric disorder, really it's severe enough. We're saying these PMS symptoms are severe enough to be disrupting work, relationships, daily functioning. Women often will go from feeling perfectly happy and normal in their lives to feeling absolutely suicidal. And it's reliable every month in the days or weeks leading up to their period. Next is peripartum depression and peripartum anxiety. Um, this happens in up to 10 to 15% or 10 to 20% of pregnancies, depending on depression or anxiety. They often co-occur. And, this is actually more common than things like gestational diabetes. So, if you are a woman who's had a baby, you were given the oral glucose tolerance test. So you were given that really super sweet liquid to drink, and your OB tested your blood glucose to see if you were developing gestational diabetes. This is mandated. This is a required part of screening during pregnancy. But gestational diabetes is less common than either of these two disorders. And we really don't screen for this. We don't screen for depression or anxiety. Every once in a while, I find a wonderful OB who is screening for these things, and I get very happy about it. But most often, women are not being screened. And part of the reason I find this really, really concerning is the risk of suicide and overdose during pregnancy and that immediate postpartum period is the leading cause of death. Not hemorrhage, not infection, it's mental health. And it's up to about 23%, so 1 in 4 deaths in the pregnancy or postpartum period is due to a mental health condition. And again, it is the leading cause. It is more common than any of the other things, all the classes you go to, all of the things you talk with your doula about in preparation leading up to the delivery. Mental health is often excluded as a thing to be worried about or to be monitoring or treating. Okay, so back to the conditions that occur in only women. Another serious illness is postpartum OCD. That's 2 to 9% of women in the postpartum phase. It's this is characterized by intrusive, unwanted thoughts, often about harm the baby. And these thoughts, we call them ego dystonic. So ego syntonic means it's something that we like something that feels good to us. And ego dystonic is this doesn't feel good to me. These thoughts I don't want. And so they're really horrifying to women who are having them. It's not desired. It's not a risk factor for harming your baby. It is actually an anxiety condition, and it's a very treatable anxiety condition. But because it is so stigmatized, it really often does not get disclosed to clinicians if if women are not being directly asked, are you having thoughts of harming your baby or yourself? And again, this is actually, it doesn't mean you want to do it. It's not psychosis. But it's really, I know it is very uncomfortable to be experiencing. So while postpartum OCD is not psychosis, postpartum psychosis does occur, and it happens in about 1 to 2 out of every 1,000 deliveries. Most often, this is in patients with bipolar disorder, untreated bipolar disorder. It is a psychiatric emergency when it occurs, and so if you or a loved one is concerned about either your mental health or a woman in that postpartum period, maybe just acting more regularly, more paranoid, making concerning statements about people watching them, stuff like that. This is when it becomes an emergency, and you should be seeking emergent psychiatric care. Okay, and the last one here is perimenopausal depression. It, as you remember from this graph here, during perimenopause, the risk of depression is actually 2 to 4 times what it is in this woman's like kind of in between puberty and perimenopause years. So perimenopause risk of depression increases 2 to 4-fold over her baseline risk. And women are already at a 2 to 4 times risk elevation compared to men. So that perimenopause period is a really high risk. a really high risk period here. Okay, moving on. Um, what I just shared with you is data that really illustrates how women experience psychiatric illness differently across their lifespan and how those hormonal changes do appear to occur, predispose women to experiencing these illnesses. And so I want to explain the mechanism quickly here, the actual biology of what's happening. And I think once you understand some of the biology, a lot of things that I felt confusing or dismissed about your own experience hopefully will make some more sense. And the short version really is that estrogen and progesterone, they're not just reproductive hormones, they're brain hormones. They cross the blood-brain barrier. You have receptor sites all throughout your prefrontal cortex for both hormones. And we've only really just mapped out throughout the whole brain where these hormone receptors are and then really what they do. And so what we are learning since 2016, essentially, is, again, ovarian hormones or neurochemicals. So this diagram here, it shows you four main brain chemical systems, and the ways in which estrogen and progesterone really directly influence those neurotransmitters. So I'm going to walk through each one because my hope is you may recognize some ways in which that has actually been your experience. So first, we'll look here at serotonin in the upper left. This is the the neurotransmitter most associated with mood, emotion regulation, just a general sense of well-being. And estrogen actually increases serotonin production. It slows its breakdown and reduces reuptake. And that is actually the same target that selective serotonin receptor and reuptake inhibitors, and then SNRIs also, the same targets that those act on. And so estrogen is essentially a potent endogenous SSRI. So when estrogen drops, you are actually losing a natural antidepressant. It's not a metaphor. This is a real mechanism of action of estrogen in your brain. Moving on to dopamine up here in the upper right. So this dopamine helps modulate the prefrontal cortex, which is part of what helps to works on your motivation, your focus, reward system. And estrogen supports this dopamine function in your prefrontal cortex. And so when estrogen is higher, your executive functioning is better, your planning, your concentration is better. And as estrogen falls, many women notice difficulty focusing, lower motivation, just kind of a general flatness to things they usually enjoy. That's that reward circuit. Down here in the lower left, we have norepinephrine. This is your arousal and your stress alerting neurotransmitter. And so it helps to modulate, essentially kind of helps work in concert with dopamine oftentimes. What we are actually attending to, because it is our arousal and stress alerting nucleus. So we are attending to what is kind of stressing us out, we are alert and awake, paying attention. And it also actually helps to regulate, this is the leading explanation essentially for why women experience hot flashes and also perimenopausal anxiety. So as estrogen drops and norepinephrine stops working as well, or as it's not getting that estrogen support, women will experience things like hot flashes, depression, anxiety symptoms. So that is the estrogen norepinephrine connection. And then on our right here, we have progesterone and the GABA system. And so GABA is a system that is affected by things like benzodiazepines, so like Xanax or Valium, alcohol. You also have your natural anxiolytics, though. So an anxiolytic is something that reduces anxiety, and progesterone is one of those things. And so progesterone in your brain converts to something called allopregnanolone. And it's really that natural anti-anxiety agent, and it works through the same GABA system that, as I mentioned, GABA, benzos and alcohol also target. And this is actually why, kind of paradoxically, some women actually feel calmer mid in kind of that latter phase of their cycle. As I show you in our next few slides, we'll look at how estrogen and progesterone rise and fall. And when progesterone rises, we do see sometimes lower anxiety in women. And then when it drops, anxiety will increase. So, when your progesterone declines, you've really kind of lost your brain's natural Valium, essentially. And postpartum, we will replace this allopregnanolone. We used to use brexanolone. It's an IV drug. Now, and I probably should update this to include zuranolone, which is another medication. It's also a um, synthetic version of allopregnanolone that we give to women postpartum to treat their depression. I just want to say, though, that everything, all four of these systems, the serotonin, dopamine, norepinephrine, GABA, they all interconnect. They are all in circuits that have more than just serotonin or dopamine in them. So if one gets affected, your serotonin is affected, really all of the others will be affected as well. And of course, especially if estrogen is going to going up or down, you're going to have downstream effects in multiple neurotransmitter systems anyways. But this is kind of why some of these hormone transitions can produce such a wide range of symptoms: low mood, poor focus, anxiety, irritability, disturbed sleep, hot flashes, all at the same time. It's not coincidence that they come together. It's really a downstream mechanism of the same hormone shifts that are occurring because of this deeply entwined network that we have going on. So, the takeaway here is simple, actually. Just these hormones, estrogen, progesterone, are integrated into your neurotransmitter systems. Any significant change in your estrogen or progesterone throughout the month, during pregnancy, during perimenopause, these are neurochemical events that your brain will respond to. And so one more piece of this. So just talked about essentially these hormones, what they do in here, but they also circulate, right? Our hormones circulate throughout our body. And I just want to go through this before we move on to what happens throughout each life stage. And so your stress system on the left and your reproductive system on the right, they're not separate. They share the same command center, your hypothalamus. And so the hypothalamus does send signals down to both systems. Stress on the left regulates threat detection, releases cortisol, which I think maybe you're all heard is our stress hormone. Um, and on the right here, reproductive system releases estrogen and progesterone. So and then there's a lot of crosstalk between these two systems as well. So changes in your estrogen and progesterone do directly talk to your stress system, to directly affect your cortisol functioning throughout your entire body, and vice versa. This is why women who, maybe are experiencing anorexia and are severely underweight, their stress system goes way up. The reproductive system says this is not necessarily an environment that is safe to reproduce in, so they'll lose their menstrual cycle. Um, these things absolutely are interconnected very, very closely. It's not two systems. This is really one system with two arms: stress and reproduction. I'm pausing here because I want to make sure that I am being clear here. I know this is kind of a lot of biology for everybody Some people are more interested or less interested, but I just want to really show you that this is something that has been well mapped out. We do know estrogen and progesterone greatly affect our neurotransmitters in our brain, cortisol and our adrenaline in the rest of our body, and that these two systems are essentially one, and they talk together. They have the same on switch, and they both converge on our hippocampus, another brain region. Um, and this whole system is just kind of one thing. Okay, so moving on. So we've covered kind of the why and the how, and now I want to get to the part that's really about you and your life, looking at the specific moments across your lifespan when the hormone shifts create windows of psychiatric vulnerability. So there are three of them: the premenstrual phase, peripartum, perimenopausal window, as I mentioned. And really each one has the same underlying logic as we just went through. The significant hormone change affects the brain, and but each one does have somewhat of its own character in the way these hormones are shifting, and their own set of conditions. And so I'm going to walk through them one by one. And as I do, see if you can kind of keep Maya from the very beginning, my fictional patient, in mind, and think about her story and how it might relate to these different hormone shifts throughout her life. Okay, so what we see here is the menstrual cycle, um, and how our hormones change across our menstrual cycle. What you're looking at is estrogen in this pink red color and progesterone in this green color across a typical 28-day cycle. In the first half of the cycle, we call it the follicular phase. Estrogen is rising dramatically, and it peaks at around 360. And then that triggers ovulation here around day 14. And as soon as ovulation occurs, it plummets again. And then both hormones build across that luteal phase. That's the second half of your menstrual cycle. And, you know, for some women, specifically those with PMDD, this is where symptoms of that, this is where their psychiatric symptoms may worsen or begin to develop. Um, you can see here progesterone peaks here at around 20, and estrogen actually has a second bump here at around 160. And this is the period of what time when both hormones are dropping precipitously between days 25 to 28. 28, or say, call it day one right here, would be the day you start bleeding again. This is when premenstrual symptoms typically occur. And so for people with PMDD, this window will certainly be a pretty uncomfortable window. Like, this is when women are really experiencing the depths of that suicidal ideation, or just the profound fatigue and irritability, maybe. But for some women with PMDD, it occurs around here. This is where that switch flips. So they actually experience 2 weeks of feeling good, 2 weeks of feeling bad, and on and on and on. Sometimes that peak, or sometimes that switch, that transition occurs sometime around here. So about 1 week prior to their cycle, and sometimes it really isn't for a few days. And so I draw your attention to that point, because when you start to experience symptom changes, it is important to be able to note. And this is helpful for people like me who treat this kind of these sorts of illnesses, to help identify what's going to be helpful for you. You know, are you particularly sensitive to estrogen dropping and you have 2 bad weeks here? Are you sensitive to progesterone dropping and you're only in that last week? Or are you more like here, where both of them start to come down? It's important to track your moods over 2 cycles. In order to have a true premenstrual dysphoric disorder diagnosis, it requires 2 months of prospective tracking, in part to help me see that pattern. These are the actual diagnostic criteria that I've listed out for you. We have depressed mood, fatigue, sleep disturbance, feeling overwhelmed, decreased interest, concentration issues, appetite changes. These are actually things that we see consistent with a major depressive episode. The things that I want to point out that are different would be irritability or anger. That's not in our typical major depressive disorder criteria. Mood swings, anxiety or tension, and physical symptoms. These are kind of the specific things that I may also be looking for to differentiate what someone's experiencing as regular depression from a PMDD picture. And then, symptoms also do need to resolve, usually within a few days of menstruation. So, like days 1, 2, 3 of their cycle, it's like suddenly the world is brighter again. They feel like they can think more clearly, their energy is better. I will say it's not always exactly then. Women have different responses to their hormones. So, again, I really like for women to track how they're feeling across the two menstrual cycles so that we can get a really clear idea of what their particular pattern is so that we can address it. I tell this to you because if you are one of these people, write down your top four symptoms right now. If it's irritability, fatigue, mood swings, is it decreased interest? Do you not sleep? Choose your top four things and then start tracking those four things. Okay, moving on to our peripartum hormone withdrawal. So if the premenstrual drop feels really significant, I just want you to look at what happens across pregnancy and birth. So this is our graph of pregnancy in weeks. So starting at week 10, going up to week 40, labor, delivery. Of course, this is expanded a little bit for clarity on the graph here, but your estrogen again is in red, and then progesterone again is in this green dashed line. Your estrogen peaks at around 19,000. If you recall from your premenstrual phase, it peaks at around 360. And then it drops precipitously over the course of days. Progesterone peaks at 150. During your menstrual cycle, it peaks at around 20, if that. So, and then also your progesterone drops over the course of hours, not days, but hours. And so this is an abrupt shift, 50 to 100 times more abrupt than even a premenstrual shift. And so when women are susceptible to or experiencing PMDD and they want to get pregnant, it's a time where this is a time where I'm really, really going to be very closely monitoring them. We know they are particularly sensitive to hormone fluctuations. And so this hormone fluctuation is going to be the greatest anyone ever experiences at any point in their life. Now, when you understand this graph and the other graph, the question really does, I think, stop being why do some women develop postpartum depression? And I think it shifts a little bit more to, well, what protects women who don't? This is pretty profound. This drop is universal, and the vulnerability is there for anybody. But what varies really is this biological sensitivity. And, that can be predicted essentially by personal and family history of mood disorders, prior premenstrual dysphoric disorder, prior postpartum episodes. Those are all clues to me that someone might be particularly sensitive. And something I haven't mentioned quite yet, a lot of times people come to me and they really want to get their hormones tested. They're like, I'm clearly really sensitive. Something's wrong with my hormones. People with PMDD, postpartum depression, perimenopausal symptoms, it has nothing to do with what your hormones actually are, if we were to measure them. It has everything to do with what your brain does with those hormones. And so a woman with sensitivity compared to a woman without, those hormones are going to look completely the same on a blood draw. We can't differentiate it through blood. But this graph is also why Maya, my fictional patient, why her instinct to stop her medication during pregnancy to protect her baby, why it's understandable. It was a really risky decision for her because we know she has PMDD, or by history now, we can see that she has hormone sensitivity. And this is a really important period to be protecting her. Okay, so going to talk briefly about our peripartum psychiatric condition. So, what can happen during that postpartum hormone crash? Really, quite a lot. So, as I've already mentioned, peripartum depression and peripartum anxiety. Those are really super common, 10 to 20% of deliveries. Um, Anxiety and irritability are often more prominent actually than low mood. And women often don't recognize it as depression. And, most women actually don't develop it just postpartum. Most of these episodes of what we diagnose as postpartum depression actually begin during pregnancy. And so it's really crucial to be screening for these symptoms during pregnancy in addition to just postpartum. Okay, so postpartum, I've already mentioned as well, women don't like to disclose without being directly questioned. Postpartum psychosis, as I mentioned before, it happens in 1 to 2 out of 1,000 deliveries. And if a patient has bipolar 1 and is not treated, so without prophylaxis means she's not being treated, her risk of having postpartum psychosis is 25 to 50%. Postpartum PTSD, also quite common, 30% after a traumatic delivery. It's often mistaken for depression. The treatments are different, so it's important to distinguish. And perinatal substance use. This is an area of particular interest to me as being someone who is both a board certified addiction psychiatrist as well as my reproductive psychiatry training. This perinatal substance use is incredibly, incredibly common. It's almost never screened for. People don't like to talk about it. As I mentioned already, suicide overdoses are the number one cause of perinatal mortality. So 7% occur during pregnancy, 7% of deaths during pregnancy are due to a psychiatric condition, 20% postpartum are due to suicide. 23% of overall maternal deaths are due to some kind of psychiatric condition. And it's just the number one cause of perinatal mortality. And so this really brings me to a central question that I hear really often from patients who are pregnant or planning a pregnancy. Isn't it safer to just stop my medication? And I want to be very, very direct with you guys here. So no treatment is not the safe option. It's not the zero risk option. It really is an option with its own set of risks that are real, that affect you and your baby, and that really need to be weighed against the risks of medication. And so I look at 4 categories here. Let's kind of go back to just category 1 here. So risk of the psychiatric illness itself to the mother. We know that if we do not treat depression and anxiety, bipolar disorder, OCD, PTSD, right, any of these things, the risk is poor self-care, preterm labor, suicide, as I've mentioned, a progression to more severe illness throughout the course of the pregnancy and then postpartum. And that risk to the fetus is elevated cortisol exposure, which programs their HPA axis, which is their stress and kind of threat detection center. So it does cross into the fetus's brain and affects their programming. It can lead to some growth restriction, so smaller than normal sized babies, and then altered neurodevelopment after delivery. Then we compare that to the risks of the proposed treatment. We're considering teratogenicity. That is the name for the risk of causing some kind of fetal malformation of a medication. And then persistent pulmonary hypertension of a newborn. This is a very, very, very low. I'll talk about this in a little bit. So we're really thinking about those 2 particular side effects, though, of treating mental illness during pregnancy. And so I think it's important to know that your baseline risk of having a major malformation is between 2 and 4% of all pregnancies. And when you're exposed to an SSRI or an SNRI, which we know from our hundreds of thousands of women who have been treated through pregnancy with one of these medications and then looking at the outcome of their fetus, of their babies. That risk is about 3 to 4%. And this is not a statistically significant difference in, oftentimes it's 3 and 3%, 4 and 4%, even if the specific study is 2 to 4%. The what we call the margin of error of the study is great enough that there is not a statistical significance. And so, yes, there are some medications I would never prescribe during pregnancy. Depakote, there are a handful of them. The vast majority of medications I would be offering a patient are, in fact, not risking teratogenicity in an infant. The persistent pulmonary hypertension of the newborn is something that's more of a theoretical risk. We don't know that it's truly there. It's something that we need a little bit more data for, or a lot more data on, and it does not appear to cause any lasting harm. So even if a baby essentially is delivered and has pulmonary hypertension, they do require more time in the NICU, the neonatal ICU, to help develop the lungs and to oxygenate, but it does not appear to have any lasting impact. We also will be considering what are our alternative treatments. So if we're not going to do psychiatric medication, can we do psychotherapy? Does the patient have access to psychotherapy? What's our monitoring plan to make sure we get her into treatment, more biological treatment if that's needed, if the therapy isn't working? And then I also will consider some of the patient-specific factors. So, how severe is this depressive episode? What were their prior treatment responses? Do they respond really well to medications really quickly? So we can kind of wait and treat only if really needed. What's this person's relapse risk? Where are they in their pregnancy? So after your first trimester, your baby's organs have fully developed, and so exposing them to medications is not really a concern for teratogenicity. What's their social support? What are their trauma? What's their trauma history, etc. And so, the bottom line here is that no treatment is not zero risk. It is just another treatment option with its own risk profile that really needs to be talked about every single time with every single patient. I don't always recommend medications for every patient, but when I do, it's usually because I have weighed all 4 of these risks and I've talked them through. And my recommendation is, after weighing the risks, it appears the risk of developing a severe postpartum or severe peripartum mental illness is greater than the potential risk to the fetus. Okay. Moving on to perimenopause hormone withdrawal. So the third window of vulnerability is perimenopause. And this one looks a little different from our others. And the premenstrual and postpartum crash are really sharp, predictable events. Perimenopause is characterized by its unpredictability and erratic nature of your hormone levels. So what you're looking at here is 16 menstrual cycles, so 16 months. And then our peak estradiol levels here, I didn't include progesterone because it usually tracks a little differently, but I think looking at just estrogen is helpful enough here. So our normal, this is our normal min 100, normal max 300, and this is our average. So the average estrogen across that menstrual cycle. And if you look across 16 months, sometimes women will be here in that normal range, and this kind of maybe just under normal in this red box here, or in the red dots. Sometimes she will be nearly zero, right? Like this number will be so low that the average across that cycle is really, really below that minimum, the normal min. And there will even be times where there are what we call supraphysiologic spikes, where the average across that menstrual cycle was much higher than she'd ever previously been exposed to during a normal month. And I show averages, and I think if we were to take one of these dots and we were to expand it to look at her entire month, we wouldn't see the natural double rise and fall of her estrogen level like we typically would. It's going to be like this, okay, like a stock market. It doesn't necessarily even rise and fall gently over the course of that month the way it previously had. So our averages are off, and then the way it rises and falls is now off. This is actually a really important reason why I don't take blood levels of hormones oftentimes from women. So if someone comes to me and they want to know am I in perimenopause, I can't do that reliably with a hormone test because we could be in this month and your hormones are normal. Um, we could be in this month and it's going to look like you're menopausal and you're not. You're perimenopausal. You're still kind of having these months where they're normal. Right, so I go based on symptoms, and most doctors should be going based on symptoms, not numbers here in your perimenopausal time. Um, and the something to kind of note here is because it's not this kind of graceful decline into menopause, this neurochemical roller coaster, as you will, it's really dysregulating. Your brain has been designed or calibrated really to a relatively predictable cycle for decades. And it's now responding to these neurochemical signals that are becoming increasingly more unpredictable. And the result, if you recall from what happens to your neurotransmitters, is wax kind of random fluctuations in your serotonin, dopamine, norepinephrine, and GABA systems. And so you're going to have mood instability, anxiety, sleep disruption, brain fog, hot flashes, and they may not have a clear pattern to them. PMDD, clear pattern, perimenopause, completely no pattern at all. And so one of the really important clinical points here is that perimenopause can occur years before your periods are irregular. You may be having regular menstrual periods throughout this. And so I'm looking actually at, again, symptoms. What's your brain fog, hot flashes, night sweats, stuff like that. And that's going to tell me where if you may potentially be in this perimenopausal window, even if you're having normal menstrual cycles still. Um, and it really can occur for 5 years, 10 years. Sometimes some people think it may even last for longer than that, potentially. So, if you're in your mid 40s and something has shifted and you can't explain it, but you're still getting your menstrual cycle, this graph may help explain this part of your story. So, you may be asking, okay, well, what am I going to do about it? Hormone replacement therapy, it's not safe for me. Right now, perimenopause is kind of really big in media, and so you guys may know more about this than I'm implying here. But up until the last few years, really for decades, many women were told that hormone therapy was dangerous, that it causes cancer, it's not worth the risk, it causes stroke, right? And I want to correct some of that misinformation, explain to you where it comes from, why it persists, and really what we actually know now. So in 2002, a very large study called the Women's Health Initiative published findings suggesting that hormone therapy increased breast cancer risk. And so for at least about 2 decades after that, women just weren't prescribed hormones. And while I really appreciate we were finally studying women, right? In 2002, we're finally studying women and menopause. The unfortunate part of this is that they really studied the wrong patients. The average age in that study was 63, 10 plus years past menopause. Just kind of brief note, we now know we must be starting hormones within about 5 years past after menopause. After 10 plus years, the risk of causing something like a cardiovascular illness is much higher, or a cardiovascular event. And so these are women we would never treat, the women who were included in the study. We would only be doing perimenopause. We only treat perimenopause or early menopause women. So, what does HRT do for the appropriately selected woman? It can reduce hot flashes and sleep disruption, reduces depression and mood instability, reduces bone loss and fracture risk. It actually decreases cardiovascular mortality by up to 50%. And again, that's starting within 10 years of menopause or before age 60. This is called the timing hypothesis. It has been a change in what we now do in treating women. It is also associated with an up to 30% reduction in all-cause mortality when it's appropriately timed. So not just a 50% cardiovascular mortality, but 30% all-cause mortality. And there used to be an FDA black box warning, and the FDA removed it from most products, primarily some of the topical products or the transdermal. And let's talk specifically about breast cancer risk as well. So this is per 1,000 women over 5 years. So combined HRT, hormone replacement therapy, with what we call synthetic progesterone or synthetic progestins does look like it's associated with about 4 additional cases per 1,000 women, comparable about to drinking 2 units of alcohol a day or 5 in 1,000. However, estrogen plus bioidentical or micronized progesterone there is no increased risk above baseline. And if you are just getting estrogen only, there's actually 4 fewer cases per 1,000. We don't give estrogen only unless you've had a hysterectomy, because estrogen only actually also increases risk of endometrial cancer. So we would only do it without the progesterone if you don't have endometrial lining, so no uterus. Progesterone protects the uterus. And whatever additional risk you were exposed to, if you had a synthetic progestin, which I don't prescribe, the risk actually disappears within 5 years of stopping the medication. And so, I'm not telling you every woman needs to take HRT, but I am telling you this because so many women fear HRT, and it's really based on a misread of a study that didn't apply to them. We looked at women who were older, women who were taking combined equine estrogen, which we again no longer prescribe. We now do bioidentical forms of hormones, and we only treat women in a certain time. So it's the timing and then the kind of estrogen, progesterone that we are giving, that we are using, actually completely changes the safety profile of HRT. Okay, so I know we've gone over an hour. My hope is you guys all have a couple more minutes. I'm gonna just skip, I think, through this because I want to get to what you guys can do differently here. So we're almost at the end. I just want to close out with really what's most practical for you here. The information without action just isn't enough. So what do you do? What do you do with all this information that I've given you? And the answer is I want you to hopefully feel empowered to bring this to your providers now. Okay, so 5 questions to bring to your appointment. Could your hormones or your cycle be relevant to what you're experiencing? So your reproductive history should be part of your psychiatric history. Every time you see a new mental health provider, share with them what it was like for you during your periods, during pregnancy or after, during peripartum period or perimenopausal period for you. I ask every time, but I am a reproductive psychiatrist. Psychiatrists aren't always trained to ask these sorts of questions. They may be something that you have to bring up to them. So number 2, if you have noticed a symptom pattern, track it with them. Make sure that you actually continue to bring this up and don't just get it dismissed as a PMS. Say, let's look at this together. Make sure you're being monitored through postpartum. Make sure your mental health is being thought about, monitored and treated if necessary. And it shouldn't just be once, but it should be multiple times, right? Pregnancy's up to 10 months, and then postpartum period is up to another year after that. So it's a full 2-year window where a woman's mental health is incredibly vulnerable. Okay, number four, what are the risks of stopping my medication, not just the risks of staying on it? So really ask, what's your relapse risk? What are the risks of untreated illness for your fetus or your baby? And then, if you're in your late 30s, 40s, 50s, and you feel like something has really shifted, your mood, sleep, concentration, anxiety, perimenopause really should be on the table as a contributing factor, even if your periods are still regular. So ask, could perimenopause be contributing to what I'm feeling? And is hormone therapy worth discussing for me? Okay. So brings me to my list of resources. I would really love for you guys to all take this down, take a screenshot or something if you need to, if you can. These are resources that I trust and frequently recommend to people. So MGH, that's Mass General Hospital or Harvard, their Center for Women's Mental Health, that's womensmentalhealth.org. Postpartum Support International, they have a provider directory of people who have this kind of specific training, a helpline, support groups for peripartum mood and anxiety disorders. So if someone or if you may be struggling, you need to find a clinician, an in-person group, a virtual group. This is a wonderful resource. Mother to Baby is where to go for medication safety information during pregnancy and breastfeeding. It's run by what we call teratology specialists. So teratology, that's the fetal malformation experts. Um, it's free, and we have a very specific medication question or exposure, alcohol, nicotine, what have you. It's a very, very reliable resource for this kind of information. And then IamPMD.org is for PMDD. It's for patients. It's patient run for a patient community, and it has diagnostic tools, information about treatments, a cycle tracking resource to help document the patterns you may be experiencing. And again, these are just my resources that I like to provide to patients so that they can seek out additional information on their own in addition to what I'm able to provide. Okay, so these are some of my resources. And then thank you for sticking with me. I went all over longer than I was anticipating. I get very excited about this topic, and I always have so much to say. So if anything I have said, is something you want to know more about and you have questions, please send us a message or call. And I see, okay, there's a question about testosterone as part of HRT. Yes. So I included estrogen and progesterone as HRT because they are the most important ones to be replenishing or to be included, that take care of the majority of people's symptoms. And we have a lot of data on what progesterone and estrogen do for a woman's body, even outside of the mental health aspect. I want to make sure that my patients are protecting their bones and their brain and their skin, their heart. So there are reasons outside of the psychiatric to be taking those hormones. Now, testosterone is super important. Don't get me wrong. I'm a psychiatrist. I think mental health is number one, super important. But testosterone often is more of a quality of life experience. How am I going to feel better? Like more energy, sex drive better, keep up muscle mass, right? So those are usually the specific areas that testosterone treats. And there are a couple of different ways you can take it. I usually just recommend doing the topical. There you can do injection, but I don't know that it's necessary. Um, there aren't a ton of risks as long as you are staying within a normal range and you do want to make sure you're getting your testosterone levels checked if you are replacing testosterone, because there are some other risks like down the line if you are over, you put yourself at risk of growing more facial hair, having acne, right? There's some uncomfortable risks too. So it's something that's a little bit more tightly managed and not always necessary, but certainly something that I will use when it feels really important for quality of life. So hopefully that answered that question. Okay, so I will Again, just reach out if you have any questions. And I will wrap it up, let you guys all get on with your day, go have some lunch. And I thank you again for coming.